Hi, welcome to SOWK913, lecture 3, week 7. Before we start, of course, I'd just like to acknowledge the traditional custodians we're on today. We are, if you're watching this lecture in your classroom, on the Dharawal country of the Wadi Wadi people. Pay my respects to elders past and present. And if you are watching this at home, I pay my respects to whoever the traditional owners are of the country that you are on today. So this is the second last workshop for this particular subject. And what we're going to be looking at is the funding and governance of human services organisations. So funding and governance is really important to understand because it often drives the what services are able to do and how they're able to do it. So this is really all taken from Carson and Kerr. I hope you've read the relevant chapters. If you have read them, this is literally going to be a repeat of what's in there. If you haven't read them, then I highly encourage you to read them as per usual. So, welfare state model of human services lived up into the 1990s. So before this, what we actually saw is that services were delivered by government and non-government organisations, otherwise known as NGOs. Like everything to do with policy, of course, it's not that simple. So you'll find that the Commonwealth Government sets the broad directions around social policy, and also that includes legislation as well as funding allocated to the Australian Public Service agencies and then shipped out across to the states and territories and to local government and then NGOs. So when it comes to thinking about state and territory government agencies and the services they offer, they're designed to be easily accessible and free or minimal. So when we're talking about state or territory run services, the idea is to make them cost effective, affordable for everybody. When you think about service providers, you think about hospitals, public hospitals versus private hospitals. Public hospitals, clearly you can walk in there and get seen. That means that the employer is the state and territory government. So in New South Wales, we have the Ministry of Health, and at a local level, we have local health districts, and they still employ people directly in the local health districts. And we'll talk about how state and territory funds some services, but there is also a fee-for-service type approach, which engages with NGOs and other service providers. So when it comes to the direct employment of health service workers by the state and territory government, it includes nurses, allied health, and other support staff, and also includes social workers. So when we think about examples of state and local run services, as I said, the local health districts often run clinics. I see a free clinic with my little one, the child and maternal health one. So, but some of the other examples are nursing homes, and then allied health and nursing staff and community health. As I said, the child and maternal health services that are available, day centres where you've got auxiliary staff, so transport workers, etc., and group homes for younger people with a disability. All of them are designed to support the community more broadly. Then we've got non-government organisations, otherwise known as NGOs. So these tend to be community-based organisations, and they're designed to actually be essentially non-government organisations are not run for profit. So any profit that they make gets fed back into the organisation to meet the needs of their community. So again, they're designed to actually be free or small fees for consumers. They often have less state weight. The salary tends to be a bit less because it's based on an award. But they're also a complex array of service providers, and they're usually very embedded within their local community. And the idea is that there's no wrong door approach to access these. So however you come in, you come in. So a couple of examples of those are Aboriginal community-controlled health services. They deliver Aboriginal health services in a comprehensive primary healthcare way, which includes things like social workers, They might have Centrelink coming in, support workers for people who have come in contact with the criminal justice system or out of home care, as well as nurses, GPs, etc. There are other models of community health around the country as well. So that's some examples of non-government organisations. So when we're talking about a welfare state model, which is welfare that is delivered by the state, some of the challenges that are perceived are that it requires a large public service. So again, looking at New South Wales Department of Ageing, Disability and Home Care, the HAC program and disability services. You often hear about long wait lists. So for example, in the news this morning, I heard that on the public system, some people are waiting up to 8 years to see a specialist surgeon. This is largely because of the demand and the limited funds. And there's a perception that the infrastructure, when the government has to actually maintain it, can be quite costly. So that includes things like nursing home buildings, group homes, and community transport buses. And often they're critiqued as not consumer focused. So because they're run by the state and they're run at a very low fee, what they're looking to do is service as many people as possible in a cost-effective way. And so it may not be meeting the individual needs of consumers. So then we're thinking about the role of human service organisations in policy and practice. So human service organisations, government, Commonwealth, state and territory, government and third sector organisations, which are what we call NGOs. So when thinking about it, we need to be thinking about how we can actually have a whole of a system approach. One of the things that's not covered necessarily in detail in your chapters is probably the private access. So you can privately go and see people that can support you. And I'll talk a little bit about that more. So there is a complex web, if you like, of services that are provided either to support people as a welfare needs, which again is the Commonwealth, state and territory, and NGOs, otherwise known as the third sector organisations. But all of it is geared to provide opportunities for people to live healthy and well lives. So in terms of how they've actually been delivered, there was a shift in about the mid-1990s to move to contractualism. So this is about competitive tendering of welfare. We've seen this increase more and more. So this is underpinned by neoliberal public choice ideology. So therefore, if we're funding private organisations to deliver public services, people will have greater choice. So the government increasingly outsourced service provision. They maintained some parameters around it. So they defined what services it wanted, where, when, and the budget, determine outputs, outcomes, reporting and evaluation, and the contract specified nature of outcomes and quality of services. So we've seen, for example, the My Aged Care packages, which are private businesses that get funded by the government to deliver aged care services to people in the community. And the same with the National Disability Insurance Scheme, where you have private contractors delivering the services, such as speech pathology for, say, children with autism, or OTs for people with mobility issues, etc. So the government sets a fee around that, and then that is delivered by a private person or organisation. So 1990s onwards, the Australian government regulation of the services, it aimed to increase efficiency and efficiency and productivity. So going back to the critiques of government-run welfare, was that it was not community focused or consumer focused, was inefficient because there was large cost to the government. So it was then outsourced using a neoliberal approach. So it sought to downsize the state role in the delivery of social services. And we've also seen this in the delivery of social housing, that is housing that people who might need, who cannot afford a private rental or to buy a house. that largely has been outsourced to private organisations and third sector organisations. So the government outsourcing arrangements are underpinned by the notion of a purchaser provider. So the government is purchasing a service from a provider, an NGO or a private sector organisation. Again, the idea to scale down the public sector, and if they're contracting out service delivery, they assumed it would be more effective because it would reproduce competitive market modelling in public sector. Now, that cannot always be achieved. Where there are small communities in rural and remote communities, there isn't the market, i.e. the number of people to actually have a competitive market, which can become problematic. So, and it also doesn't take into consideration, as it says there, the nature of validation of human motivations, biological, physiological, and social aspects of individuals. By relying on a market-based, there has to be enough people to actually meet the needs of individuals with unique needs. So the idea was to promote individual self-determination, minimizing welfare dependency. So this is that, again, this individual consumer choice. So it treats the consumer as if they it treats the consumer as they have the capacity to make informed choices that are in their best interest, and also promotes this notion of user pay. So again, we're talking about very complex health needs, and it promotes choice. Of course, that choice is not always available if there's not a market. So you may have one provider that delivers speech pathology, for example, because there isn't a big enough market for two people. So it doesn't necessarily promote choice. Contractualism in the new public management. So it was a really, the contractualism, so that's the fee for service approach, really was a significant change in the service delivery model for governments. It became a quasi-market-based model because there was limited funding, so the government capped the budget around it. We hear that conversation in relation to the My Aged Care package again, and the National Disability Insurance Scheme, so the NDIS. So with the My Aged Care package scheme, there's a number of different levels. The government will only fund a set number of those levels in any particular area. So essentially an older person over the age of 65 that is looking for to go on the My Aged Care package at a particular level either has to wait for someone to move up a level sometimes, or until someone dies. So it is capped, so it's not a genuine market-based approach. And it's based on the premise that private markets create cost efficiency for government. So NGOs and private providers, they offer lower wages and they've used contracted staff that may they don't have full-time staff, or they may not be on long contracts. The idea is that there is an important role for volunteers in these service deliveries. And again, what happens here is that the government has outsourced the risks associated with service delivery. So they've passed on that risk to the new provider, and either an NGO or to a private provider. And again, it's an introduction of user pay. So the consumer may get, say, with the National Disability Insurance Scheme, as well as the My Aged Care package, they are given a budget around certain things that are approved by government that they can have. Let's just say for elderly people, it's lawn mowing and shopping. And so they have a budget that's allocated to them. They then get to spend that budget using their free choice by identifying the appropriate providers. And so private for-profit organisations are completely new players in the human service delivery. So again, this was downsizing of government services and public service. This was done under the John Howard government. John Howard was in government for, it was either 11 or 13 years, up until 2007. And again, we saw the privatisations of job agencies, private prisons, and private aged care homes and nursing services enter the market. So what has competitive tendering done in terms of creating problems for social welfare policy? Well, it threatens equity. It is more incompatible with diverse and complex needs of people. Again, when we're talking about a market-based model, people with complex needs take up more time And the way the system is set up, it doesn't all the government doesn't always pay for all of that time. I was having a conversation with my GP about that, actually, where she was talking about where a number of the conversations we have aren't covered by Medicare items. And so she gets paid for some of the work she does with me and many of her other clients, but not for all of them. So the notion of service user as an active consumer is problematic, as people often, as I said, have narrow range of choices, and they may not necessarily understand what all of their options are and to be able to take an informed decision. Also, it changes the relationship between the third sector organisations, which often actually advocating for particular approaches with government. So you've seen the ACOS policies, for example, where they're advocating for governments to take particular approaches on a range of different issues, including the budget. And now they're actually not just actually providing advocacy, but they're also now delivering services, not ACOS, but other NGOs. And again, as social workers, you may face a dilemma while seeking to optimize social services outcomes under the third sector organisations, but you'll be limited by whatever the contractual arrangements are with the government. So, core business of welfare is to provide public social service to address disadvantage and need. And again, when you're talking about neoliberalism and you're talking about market-based, it conflicts with the ideologies of an NGO. So NGOs are there designed from a values-based to meet the needs of the communities that they're there to service. So again, it puts NGOs, which are value-based, pits them against private for-profit providers. The other challenge you have is that NGOs are often smaller, so they're competing for funding with larger, well-resourced organisations that may be for-profit organisations. And sometimes it takes them away from their core business just to actually maintain their services. We saw this with the NDIS. When the NDIS was actually initially delivered, I heard anecdotally from a number of organisations that had to pick up just to maintain their staff because of the short-term nature of the contracts that they were receiving from government, to actually take on different types of services that they hadn't before, that took them away from their core business. What this often means is that organisations end up with multiple funding sources with onerous contractual requirements. So they have to report against each and every contract that they have. There's not just one more reporting mechanism. They have up to 100 for one of the services I've worked with, contractual obligations with government that they have to report on annually. So of course, what this often does, when you've got contractual arrangements, which may last for 1, 2, or 3 years, that means that people don't have job security. And also that means the organisation has limited funding and doesn't always know that they're going to be able to support their clients in this way in the future. So again, I've seen this happen where, again, Aboriginal community controlled health organisations, their funding was insecure. The government hadn't rolled over their 3-year contracts there for their core funding. And what that meant, people, because they had to put food on the table and pay their mortgage, were actually leaving the organisation for other jobs. So it left the organisations, the Aboriginal organisations, in a bit of a pickle because they had lost good staff because the government contracts were delayed due to no fault of their own. So staff are adversely impacted by the competitive tendering, also in terms of wages and conditions, because to secure a tender, you actually need to demonstrate that you are the most cost effective, which usually means you are offering a service you are offering a product at a cheaper price, which then limits not just job security, but career development, because organisations may not have the funds to invest in their staff, nor do they necessarily want to invest in staff that may not be there in the not too distant future. So this leads to an unsustainable situation with human services. So the unintended consequences of contractualism is it undermined efficiency of human services. And again, increased complexity for clients because they then had to go and make choice around this. But again, their choice may be quite limited. And again, it really impacted NGOs, local community organisations, who were advocating for specific approaches for their local community, but at the same time being required to rely on the government for services. And again, small NGOs don't always have the capacity to be to deliver a request for quote. So an RFQ is often what goes out when the government's contracting a service. And they don't have the capacity because they don't have the staff of the larger organisation. But the larger organisations often don't know the communities as well as a smaller organisation. And again, there's a decreased willingness of NGOs to collaborate and network because of the nature of competitive funding, which again goes against their values base. So when we're thinking about third sector organisations or NGOs, the relationship between government departments and third sectors can be complex, again, because of that advocacy component and also the service delivery component. It really does limit joined up solutions for joined up problems. So when we're thinking about the continuity of care for individual clients, when you've got services that are actually in competition with each other, they're not necessarily going to work efficiently to meet the needs of those individual clients because of the nature of the business. Partnerships, which improve the coordination effectiveness of integrated human services. Again, when you're in competition with people that could be your partners, this is less likely to occur, and the same with collaboration. And also having competitive tendering increases regulation and reporting, taking services away from the core business, which is service delivery. So there's a quote here from Carson and Kerr in relation to the impact of contractualism on the third sector management and social policy. The more general problem with neoliberalism is the impact it has beyond the economic. It involves renunciation of the public sphere, indeed of any collectivist ideologies and practice. It is a viewpoint which imposes the basic principles of the marketplace over society with all its more complex sources of social cohesion and vitality. It paves the way for a dehumanizing corporate managerialism. So some food for thought. Thank you for listening, and I hope that you enjoy the rest of your workshop.